diagnosis of intracranial infection. And I have mentioned before that there are two main indications for contrast injection in the CT and the MRI. The first one is the suspicion of infection, and the second one is the tumors. Then, before we inject contrast material, we need to assess the renal function. And this is now routine. Before injecting contrast material, you should have information about the creatinine level. And I put these numbers from the internet in order to know the normal levels. And this is the normal serum creatinine for males, and this is the normal serum creatinine for females. And in my opinion, I accepted 0.2 above this number, and I go for injection of the patient with contrast material. I do not stick for 1.3. I may inject the patient with creatinine level 1.5, provided that you injected the patient with non-ionic contrast material and you instructed the patient to drink a lot of fluids after the examination. You should know that the patient, in order to have an appointment for the examination, it takes some time and some effort. Then after this time and effort, the patient came, then you say that, oh, creatinine level is 1.2. No, I cannot perform the examination. This is an aggressive attitude, I think. But I accept my opinion or my personal attitude in my working place is a creatinine 1.5 is acceptable, provided that you inject the patient with non-ionic contrast material and you order the patient to drink a lot of fluids. And if you inject the contrast material and you got an marginally enhancing lesion, and this is an abscess, if you get a thickened dura that is enhancing, and this is meningitis. This is the normal thickness of the dura. As you can see, it's a very fine line that normally enhances with contrast material. But this line is very thick and is strongly enhancing and also seen in the interhemispheric fissure. Then we have a lot of intracranial infections. And we have the congenital, we have the viral, we have the bacterial infection, we have the granulomatous infection, the fungal infection, parasitic infections, and HIV-related infections. We'll start first by the congenital or neonatal infections. Neonatal infections occur intrauterine, and you remember the abbreviation, the TORCH. TORCH stands for Toxoplasma, Rubella, Cytomegalovirus, and herpes simplex. These infections will result in intracranial calcifications that are distributed in the periventricular region, haphazardly distributed. And the trial to diagnose one of these is not possible. If you see multiple periventricular calcific foci, then you say that this is periventricular calcification diagnostic of congenital intracranial infection. At the era of CT, before MRI, they said that if you see that the calcium is intimately related to the wall of the ventricle, then you suspect cytomegalovirus infection. If the calcium is away from the wall of the ventricle, you suspect toxoplasma infection. Nothing of these is true. But if you see calcification scattered around the ventricle, you say that this is congenital intracranial infection. And these congenital intracranial infections are remembered by the abbreviation TORCH. TORCH is Toxoplasma, Rubella, Cytomegalovirus, and herpes simplex type 2. Cytomegalovirus is one of the viruses that belong to the herpes group, and they are present in the human body, and they are activated when the immunity of the body is lowered, either due to systemic diseases like diabetes, for example, or systemic drugs like corticosteroids and immune inhibitors for organ transplantation, and so on. Then you remember that the small calcifications seen on the CT are not seen on MRI. And this is an example. This is a patient with cytomegalovirus, see periventricular calcification that are not seen in the T1 nor in the T2 weighted image. So if you started your exam by MRI, you will miss the diagnosis. If you know from the history that this is a congenital intracranial infection, then you should include in the protocol the gradient images. Yes, this is very important. And if you see a CT scan like this, dilated ventricles, periventricular calcifications, either intimately related or non-intimately related, then you diagnose congenital intracranial infection, the TORCH. The second type is infection of the brain by viruses. And usually, infection of the brain by viruses is related to the immune status of the patient and is usually seen in immune suppressed patients. Immune suppressed patients may have cancer treated by chemotherapy, may have AIDS, may have organ transplant, receiving immunosuppressive drugs. Then viruses in the brain will result in meningitis or encephalitis. Meningitis or encephalitis. The symptoms are very important because the symptoms of meningitis and encephalitis are quite different from the lesions that can be mistaken for this, as I will show to you. You should got fever and you should got headache, nausea and vomiting, some personality changes, memory loss, hallucinations, and unusual behavior. A change in the personality is very important beside the presence of fever. Fever is very important. And if you look to the CT scan, you will got multiple areas of hypodensities. And these areas will not enhance with contrast. If you inject contrast material, they will not enhance. And they are multiple and maybe bilateral. And this can be easily discriminated from an infarction. Infarction is hypodense and is cortically distributed, and it has a mass effect whenever it is acute. But infarction in the pediatric age is not that multiple, is not that bilateral. And the clinical picture of fever and headache and so is very important to decide that the patient has an encephalitis, not an ischemic insult. And here you see a girl, 5 years old, fever, disturbed conscious level. Seizures is very important. Severe gastroenteritis before 1 week. Then in the CT scan, you got patchy hypodense areas in the frontal lobe, as you can see, bilateral and symmetric. The frontal lobe is not a usual site for infarction. The bilaterality is not seen in an infarction frequently. Then, if you have an MRI, you will got subtle hypo and low signal in the T1, high signal in the T2 and the flare. If you inject contrast material, you will see nothing. But if you have the diffusion weighted images, and you know that infection has diffusion restriction, and this is one of the valuable images for differentiating the inflammatory lesions from neoplastic. Most of the tumors are diffusion free. Infection is diffusion restriction. Then, one of the common encephalitis in the brain is the herpes. Herpes encephalitis is one of the fatal types of encephalitis, and the mortality rate may reach 60%. And the location of the lesions are very characteristic, so that you do not need brain biopsy to reach the diagnosis. Many times because of the appearance of the lesion may be similar to other pathologies, you may need to have a biopsy. But with herpes, the literature says that you do not need, because the lesion is characteristically located in the temporal lobes. And this lesion may be unilateral or bilateral, may be symmetric or asymmetric. And it appears of low signal in the T1, high signal in the T2, and the flare. If you inject contrast material, it will not enhance. If you have the diffusion weighted images, it will produce diffusion restriction. These are two cases of herpes encephalitis. The first one is unilateral lesion located in characteristic location, which is the temporal lobe. And the second case is bilateral lesions with predominant temporal lobe affection, and the lesions may spread to the frontal lobe and to the occipital lobe as well. The lesions are of low signal in the T1, high signal in the T2 and the flare, and they will not enhance, and they will show diffusion restriction. This is the appearance of herpes in bilateral, symmetric or not symmetric. The clinical picture is very important. In this particular example, you see a girl, 2 years old, and she has already diagnosed, confirmed to have herpes encephalitis by CSF analysis. You see a lesion in the temporal lobe on the right side. And this lesion is of bright signal in the T2 weighted image and the flare, with a small focus, which is of little bit intermediate signal in the T1 and dark signal in the T2, denoting hemorrhage. And encephalitis may bleed sometimes. If you inject a contrast material, you see this appearance, but in the diffusion weighted images, and you see the restricted diffusion. And this is the site of the bleeding, and you know diffusion has nothing to do with bleeding. If you have the MR spectroscopy, this is the normal brain spectroscopy. The voxel is located on the normal temporal lobe, and this is the spectroscopy of the herpes encephalitis. In the spectroscopy of herpes encephalitis, you got lipid and the lactate peak, and you got depression of the N-acetyl aspartate and some elevation of the choline and myoinositol. Forget about this myoinositol, but this is the difference between a similar lesion, and this is glioma. Glioma will show significant rise in the choline and the significant depression in the N-acetyl aspartate. Then sometimes, beside the diffusion restriction of the herpes, you may need MR spectroscopy to confirm the diagnosis. And this example of a child 2 years old with fever and symptoms of viral infection, you got bilateral symmetric lesions in the temporal lobes and in the thalamus. The follow-up study of this patient will show the end result or the expected appearance of the herpes encephalitis. It will cause significant brain damage and areas of liquefied brain tissue known as encephalomalacia, with consequent dilatation of the ventricles to compensate the loss of volume. And this is frequently seen in the pediatric hospitals, where the patient had herpes encephalitis or any type of encephalitis, and the follow-up will show the end result of this attack of infection, damage of the brain tissue, many areas of liquefaction or encephalomalacia. Sometimes you may got calcification, but you do not see contrast enhancement if you inject the contrast material. And this is to compare the normal appearance of the brain by the what is known as post-encephalitic sequelae. Post-encephalitic sequelae is the brain you see. Complete damage, areas of encephalomalacia, dilated ventricles, you may see calcium in the brain tissue. One of these encephalitis is known as Rasmussen encephalitis. This is an inflammatory lesion of unknown origin, usually seen in children around the age of 10, and the main presentation is by seizures. The appearance on MRI is similar to herpes encephalitis, but the difference is this Rasmussen encephalitis is in unilateral disease, and frequently it will result in atrophy of the affected hemisphere with marked dilatation of the lateral ventricle of the hemisphere affected. The symptoms are hemiparesis, hemianopia, and speech disturbances. And you see here that there is atrophic brain tissue on the right side, diagnosed by dilatation of the cortical sulci, dilatation of the ventricle, ipsilateral shift of the falx, and these atrophic changes. If you do not know anything about the patient, you diagnose hemiatrophy. And hemiatrophy has many underlying causes. But if you know that this patient had an inflammation before that, and this is the follow-up study of him, then you know that this is Rasmussen encephalitis. This is a male, 35 years old, mentally disturbed, admitted to the emergency room due to long-standing intractable seizures since he was 10 years, with progressive cognitive loss and mild light-sided hemiparesis. Then you know that this changes dating back since many years ago, and there are atrophic changes and dilatation of the ventricle. Then you may assume the possibility of Rasmussen encephalitis. The differential diagnosis will include this syndrome, Davidoff-Mason syndrome, which is the hemiatrophy of the brain, Sturge-Weber, and unilateral megalencephaly. And we'll discuss this particular issue in the pediatric brain, inshallah. Then the next type, the third type. The first one is congenital intracranial infection diagnosed by calcification. The second one is viral encephalitis. The third one is meningitis. Inflammation of the meninges can be caused by any organism, viral, bacterial, granulomatous, fungal. Any organism can cause meningitis. And the affected meninges will be thickened and enhanced with contrast material. If the meninges are inflamed, this will obstruct the absorption of the CSF by the arachnoid villi in the subarachnoid space, resulting in hydrocephalus. The inflammatory granulation tissue adjacent to the vessels may result in venous thrombosis and arterial spasm. Extension of the inflammation to the subdural or epidural space will result in accumulation of pus in these spaces, resulting in subdural emboyema or epidural emboyema. If the infection has extended from the meninges to the brain, then you may got infected brain tissue and infarctions. Finally, if the infection has reached the ventricular wall, then the ventricle will be inflamed, and at that time it is known as ventriculitis or ependymitis. In the pre-contrast scans, you may see nothing, but sometimes or many times you see dilatation of the ventricles due to communicating hydrocephalus. Diagnosis of meningitis needs to inject contrast material. Then if you inject the contrast material, you got enhancement of the basal cisternas and CSF, as well as the dura itself may be enhanced. And this is an example. In the pre-contrast study, you see distension of the temporal horns, meaning that the ventricles are dilated. After injection of contrast, and you see enhancement of the basal cisterns, enhancement of the quadrigeminal, the tentorial leaflets, and the cerebellar folia. Enhancement of the CSF spaces, meaning that the inflamed meninges here are the leptomeninges. Leptomeninges are the arachnoid and the Bayer matter. But if the dura is inflamed, this is known as pachymeningitis. Pachymeningitis. Many times, inflammation, spread of the inflammation from the meninges to the brain tissue will result in this disease, meningoencephalitis. And the diffusion weighted images are very helpful to see the affection of the brain parenchyma due to inflammation, and the enhancement of the meninges and the leptomeninges due to meningitis. And this is an example of epidural emboyema. You got accumulation of pus with enhancement of the margin of the emboyema. This is not the case of epidural hematoma. Epidural hematoma will not enhance with contrast material, even if it is in the chronic phase, if it is black. But the epidural hematoma needs a history of trauma, is usually hyperdense, and sometimes it may be a hypodense, but it will not enhance with contrast material. An accumulation of pus in the falx or in the tentorium, as I have mentioned, considering the hemorrhage, should be in the subdural space. Then the lesion is of low signal in the T1, high signal in the T2, surrounded by edema, with marginal enhancement and diffusion restriction, which is very important for the diagnosis of abscesses. Inflammation of the meninges may affect the venous sinuses. Then you got thrombosis of the internal cerebral veins, thrombosis of the vein of Galen, thrombosis of the superior sagittal sinus. If you see the vessels are hyperdense in the pre-contrast study, then you know that the blood is coagulated inside these vessels. If the inflammation reaches the ventricular wall will be inflamed. And if you inject the contrast material, the wall will enhance with contrast material. And this is diagnostic of ependymitis or ventriculitis. The fourth type of intracranial infection is by bacteria. Viruses produce encephalitis. Bacteria produce cerebritis. Cerebritis is quite different from encephalitis. Encephalitis are caused by viruses. Cerebritis are caused by bacteria. Bacteria will affect the meninges, resulting in meningitis, will affect the brain parenchyma, resulting in cerebritis and abscess formation. Remember that viral encephalitis will not proceed to an abscess formation. It is the bacterial infection that will go to form an abscess formation. Okay? Then the symptoms are the same. You should have fever, headache, nausea, vomiting, personality changes, and so on. The bacteria may reach the brain through the hematogenous route, through the direct route from the nearby sepsis, from the trauma, or embolic from congenital heart disease. Bacterial infection is seen in immune competent or immune compromised, but viruses, fungal infections are usually seen in immune compromised patients. The very early affection of the brain parenchyma will result in what is known as cerebritis. And this cerebritis by time will proceed to liquefaction and abscess formation. If you are confronted by a patient in the stage of cerebritis, you will never be able to diagnose. And you will go for tumors. But If the patient had enough time for this cerebritis to be transformed into an abscess, then the diagnosis is quite easy. Okay? So in our countries, we do not usually the stage of cerebritis. It is seen only in the internet. And you got a lesion, and they said, we assume that this is a new plastic, and we go for biopsy. Then the biopsy results appear that is cerebritis, just cerebritis. This is the scenario. But if the lesion has liquefaction and marginal enhancement with diffusion restriction, then you know that you are dealing with an abscess. And this is the classic appearance of an abscess, marginally enhanced lesion with diffusion restriction. And you should remember that the abscess in the T2 weighted image has a low signal wall. This is not the case for tumors. The abscess has a low signal wall, and it can be clearly identified because of the fluid inside and the edema outside. But the wall of the tumor is not of low signal in the T2 weighted image. Then if you see the CT scan, and you got marginal enhancement with vasogenic edema. In the exams, you got a cerebellar abscess. Whenever you are confronted by a cerebellar abscess, look for the ear of the patient, because it is usually coming from the ear. And you see inflammation of the otitis media, for example, and this otitis media is the cause of this cerebellar abscess. Abscesses are liable for complications. The complications are three. Number one, daughter abscesses, meaning that an abscess with the development of another one and another one in the nearby area. Number two, extension to the ventricle, resulting in ventriculitis. And you may be able to appreciate that the ventricular wall is enhancing, and the fluid inside the ventricle is not that similar to the CSF, because it is pus. This fluid is turbid fluid due to inflammation. If the abscess has reached the meninges, it will result in meningitis. Then ventriculitis is diagnosed whenever you see that the ventricular wall is enhancing, similar to an abscess, and the fluid inside the ventricle is no more similar to the CSF, because it contains inflammatory debris and pus. Many years ago, they suspected that ventriculitis is a complication of shunt tubes. But now, ventriculitis can be seen in patients with brain abscess, can be seen in patients with meningitis, can be seen per se without any predisposing factor, like in patients with infection in the spine or injection through the lumbar puncture, maybe not that sterile. Then you got inflammation with CSF that is directly transformed to the ventricular wall. Sometimes they said that if the patient had meningitis and you give him the proper treatment but he's not improving, you suspect that this meningitis has reached the ventricle and that the patient had ventriculitis. And ventriculitis is a very, very bad disease. It's very resistant to treatment. The ventricles will contain pus or debris, and this debris will accumulate in the posterior part, forming fluid levels, as you can see. Then ventriculitis may be a complication of brain abscesses. If there is a brain abscess that has reached the ventricular wall, ruptured inside the ventricle, then the ventricle is inflamed, and you got enhancement of the ventricular wall, meaning that there is a ventriculitis. هذا وبالله التوفيق.